Welcome to another episode of Single Payer Radio. We broadcast our program from the historic Habron Building in downtown Louisville. This show is a project of Kentuckians for Single Payer Healthcare, and we're an affiliate of the Kentucky chapter of Physicians for a National Health Program. The views and opinions expressed on our show are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. Single Payer Radio can be heard here on WFMP 106.5 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our signal, you can live stream us. Just go to forwardradio.org. WFMP is an all-volunteer station. We rely on the community for your ideas and our funding. Join us, forwardradio.org. Doctors Mike Flynn and Gene Shively are back in the studio. Mike?
Yeah, this is Michael Flynn, retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer. Any comments I make on this program represent my personal views and do not represent the views of either the Department of Surgery or the University of Louisville.
Also, my views are those of mine, not the Department of Surgery, nor the Taylor Regional Hospital in Campbellsville, Kentucky.
So today's program is part 2 of a program on Medicare for All. We did part 1 in last month, and for those of listeners who may have missed it, when it was broadcast, it's on the SoundCloud. And we have 2 very knowledgeable guests back to keep us informed about this issue. Kay Tillow is the chairperson of a Louisville chapter of Kentuckians for Single Payer. And Garrett Adams, a retired physician and the past president of Physicians for a National Health Program. So Garrett and Kay, welcome back again, and thank you again for your willingness to come on and talk with us about this important program and help our listeners understand why we need to be looking at this in a serious way. As we have done in the past, we'll give you both an opportunity to make whatever comments you'd like to make for as long as you'd like to make them, and then Gene will start with the first round of questions. Before you start, I would ask you that in making your opening remarks, there's, I believe, a bill before Congress by Senators Sanders and Warren addressing the issue of Medicare for all. And I would ask you both, maybe you could help us understand the details of it and our listeners. So, Kay, ladies first, we'll give you the floor for as long as you want, and then we'll let Garrett carry on after that. So the floor is yours, Kay.
Thanks, Mike and Jean. Happy to be here. Yes, the legislation was introduced just recently in both the House and the Senate, called, I believe, the Medicare for All Act of 2023. And there is a version in the House is sponsored by Representative Pramila Jayapal. And I have read her bill because she had that out in advance of the introduction. And the one in the Senate is sponsored by Senator Bernie Sanders. I believe that I have not been able to read that bill, although, you know, he's had bills in the past that I'm familiar with. But the bill in the House has 112 co-sponsors, including Representative Morgan McGarvey from Kentucky's 3rd Congressional District, who replaced Congressman John Yarmouth, who was also a co-sponsor of the Medicare for All bill. So it's a new effort to put this issue on the nation's agenda. And the truth is that our healthcare system is more costly than any other world. And yet, despite the fact that we spend about double what other industrialized nations spend per capita, we have worse outcomes. We do the worst on solving amenable deaths. In other words, things that could be solved if our healthcare system was efficient. We are doing very poorly at that. Our life expectancy is going down. Our maternal mortality rate is going up, and we need to remove the profits from healthcare and to pass legislation that would resolve that, either national single-payer healthcare, which is also shorthand for improved Medicare for all, or a national health service. But anything less than that doesn't really tackle the problem that the profit makers are destroying our ability to have a decent health system.
Jane, I'm sorry, Garrett.
Yeah.
Your turn. Perhaps you
thanks.
could address some of the specifics of this bill if you've got those in front of you.
Yeah.
Thank you.
And thank you, Mike and Jean. And it's a privilege for me to be on the program with you all and with Kay. And I'm really excited about this new bill. I've been spending a lot of time with it, especially this morning. And right toward the end, I found something that in the bill that I didn't know about, which really excited me. And I can't locate it right now, so I'll have to just kind of tell you what it says. But it basically says that there will be special attention in for rural areas and for underserved areas. There will be increased funding for clinics in primary care, and because of the lack of availability of medical care in the Tennessee community that I know very well. It's a place where I've had the opportunity to talk on your program before about the Beersheba Clinic, a small little community on the Cumberland Plateau of 456 souls, but they're too poor to get the health care that is there. But when we get the improved Medicare for all, we can just fold our clinic into the plan, and we won't have to worry about funding the clinic anymore. We'll actually have the health care as part of the overall Medicare for all plan in the country. So that really excited me when I understood that could happen. It's the PNHP, the Physicians for a National Health Program, has a website which is easily accessible to anyone, and I recommend that we could, anyone who's really interested in health reform, look at that site. They've broken the Healthcare Act presentation on the website into three parts. The first is a simple summary, and then the next is a section where they provide more detailed information about various parts of the bill, such things as entitlement, who is entitled. Everyone is who is a resident of the United States can be entitled to the to the benefits of the act. There is no discrimination. It will go into effect over a 2-year period. Individuals who are less than 19 years of age or over 55 years of age can be enrolled in the first year after the enactment of the act. Everybody else will go in the next year. There's the only prohibition of this act is duplicating coverage. That there be it'll become illegal to duplicate coverage by either private sale or by employers. It allows sale or oh, that was a note. I can't read. I can't read my own note there. Let's see. So, and then the next section is about the comprehensive benefits, including prevention, and includes long-term care. Long-term care was something that wasn't in one of the early benefits, but the benefits are comprehensive. The payment goes to providers as determined by medically necessary or appropriate care, and there's all usual healthcare needs. Also includes abortion as required, gender affirming surgery, dental, audiology, and vision benefits, transportation, long-term care, hospice care. These are these comprehensive benefits that are in this new act. There'd be no cost sharing, that is, there'd be no deductibles, co-pays, and so that's basically the benefits. There was one thing that I made a special note of. One of our friends, who's a member of the Kentuckians for Single Payer Healthcare, told us yesterday that she'd been to an orthopedist who was about her knees, and he was concerned that if we had the government funded healthcare, and it's probably well to make a distinction now. Mike did this well at the last time we talked. What we're talking about for everybody to just keep in mind is simply a payment plan. There's a trust fund that is set up with the funds that are already now available in Medicare and Medicaid and the Children's Health Insurance Plan. All of those are folded in and become a part of the backbone of the Medicare trust fund. So when we have have that. Oh, so I was talking about, so it's a payments plan. It's not, it doesn't have any control in any way, basically, of the delivery of health care. Because it's simply built on the backbone of the best, really, of the American medical establishment, not necessarily the recent privatized areas, but so it's a payments plan, so that we take the best of American medical care as it currently exists, and payment to groups or to institutions is on a fee for service basis. There's a global funding for institutions such as hospitals, so that they can are paid for what they spend, but they're not paid for capital expenses unless it's approved. But it's a payment plan. It's an insurance plan that takes the place of current private health insurance, which is choking the breath out of the American populace. I think I've probably said enough at this point, but I will point out that the plan as described in the act will set up regional offices with regional directors, so that there's some familiarity by locality, so that the healthcare needs and assessments and things are by reported regions.
Thank you, Garrett, Ed K, both of you. Let me, I can just, before I ask Gene to fire off the first question, emphasize what you had just said, Garrett, because I think this is an important thing that is not understood not only by our listeners, but many people in the medical profession. Is Medicare for All is a government-run health insurance plan. It is not a system like they have in the United Kingdom or some Scandinavian countries where they run the healthcare system. Everything else that goes on in healthcare, the pharmacies, physician practices, the hospitals, are all going to be carried out in the same way they have for the last number of years. The only difference would be, instead of having 1,000 for-profit health insurance companies, at least one option will be a all-inclusive government-run, federal government-run health insurance program. Gene, you want to fire off the first round of questions?
Yes, well, this is all quite interesting, and I think everybody agrees that this is the way we should go. But the real question is, what are the chances of getting something like this passed in Congress? And the other thing is that the for-profits are expanding at almost an exponential rate, and how do we take so much money, and how's Congress going to say, no, you can't make a profit anymore? What's going to happen to those companies? Are they going to become non-for-profit? How would practically go from what we have now, which is essentially an industry, to a system like this that's not for profit?
Well, Gene, those are very, very good questions and deserve an explanation and indeed a lot of thought on the behalf of the American people. I think that one thing we have to consider is that the current system does not work, and that the rest of the industrialized world and some nations that are not so wealthy have a better system that does better at outcomes, at taking care of their people. So if it's possible in other parts of the world, why isn't it possible here? Particularly since we have seriously a majority public opinion. And in a democracy, which this is supposed to be, we strive to make it so, the public opinion ought to be able to move a Congress and to pass legislation. So I'm not saying that this is easy, but I'm saying that it has to be done, because the truth is nothing less than a not-for-profit, improved Medicare for all, national single-payer system can solve the problem. The problem is so deep. 68,000 people die every year because we don't have a healthcare system, and many more are thrown into bankruptcy or have worsening disease because of the delays. We have a system that's being taken over by private equity and venture capital, and not only are they in the purchase insurance, but they're also deeply in the Medicare system. So we have a crisis that demands a solution. Solution has been proven to work all over the world. So it can work for us here too. And we have to find the ways to move forward. We cannot, we have many people who say, well, what you said, Jean, that, we're faced with big money influencing the Congress, and therefore, how do you move forward? But we have to say that once you find the policy that will solve it, then you have to frame the politics around the policy and say, what will it take? And that those who will not come to the aid of the American people don't deserve to be sitting in the halls of Congress. And we have to build a movement that's powerful enough to make that happen. Yeah, it's difficult, but it has to be done because we don't have another alternative.
Well, that's one of the reasons we're doing this program. We're not getting paid for this, and we're hoping someone's listening. Garrett, your thoughts on?
Sure. Yeah, thank you, Kay. I found the note that I wanted to share because it's an answer to a concerned physician in the Lexington region. I don't know who it is, but he was afraid that the plan would take away his independence. And I'm going to see if I can read you. Can you hear me now?
Yeah, we're hearing you fine.
Okay. All right. This is in Title II of the Act. I'm reading directly from the, actually, this is the summary statement from the Title II, but it allows healthcare professionals who by their scope of practice and licensure can exercise independent professional judgment to override national practice guidelines if consistent with the professional's assessment of the individual in the individual's best interest and consistent with the individual's wishes. So I found over and over sensitive paragraphs in this bill that I agreed with and I was happy about. I'm at a point where, for example, when they're saying they want to really help us in rural areas and when we are underserved, my little community is in Grundy County, Tennessee, the poorest county in the state of Tennessee out of 92 counties. And this could help us. It could make a big difference because people are just actually they do come to our clinic now. So we've actually seen life expectancy go up in Grundy County since our clinic was established in 2010. But if you know why I would be thrilled to have the help of the U.S. government with providing health care to this community.
Well, there's a lot of misunderstanding about the specifics and the details of Medicare for all, not just in the general public, but in the medical community, which is one of the reasons that I keep emphasizing that this is a health insurance program and not a takeover of the healthcare system. But let me ask you both. I want to make some comments about other countries' systems and their relationship to the for-profit health insurance companies, and see what your thoughts are about how that would fit in. If and when we get to the point of having a non-for-profit government-run system. The Canadian system, which was established in 1984, covers hospital and physician costs. It doesn't cover pharmacy, hearing, sight, and the Canadians need to get some other kind of insurance, and they have for-profit health insurance availability in Canada if you want to have it. In Australia, a similar Medicare for all type of system, they also allow, or they have private health insurance if you want it. Another comment about the Canadian or the Australian system, they have a Department of Rural Health. So they have a department within their government healthcare system that focuses on providing adequate health care for the outback. And again, New Zealand, and the reason I mention these three countries is that they're all very similar to our country. They also have a government, federal, central government-run health insurance program, but it also allows for-profit health insurance. So they've all figured out a way that the for-profit health insurance companies don't necessarily go away, but they're not dominant anymore. So again, let me ask Kay first, and then Garrett, if you, how do you see, down the road, if we get to that point, which we all hope we will, because that's why we're here. Where do you see the for-profits or the private health insurance companies? Where do they fit into this equation?
They have no place in healthcare, in my opinion. They do damage. They delay care. They enter into arrangements that cause massive administrative waste. That's why we're spending so much, 30% now of our healthcare dollars on profit and administrative waste. I know there was a recent Supreme Court case in Canada that everybody was watching very closely, because there was a Dr. Day who was challenging, the doctors in Canada, if they work in the national, within the provincial, in the healthcare system and are paid by it, they cannot also collect private money as well. And they wanted to break that down because there's an effort by the for-profits to retake healthcare as a place in which to make a lot of money. And that was held in Vancouver. It took a long time to get through that, but Dr. Day lost his case, and they still maintain the banning of providers who work in the system to also take private money as well, which is really key, because we can't have for-profits in there and without them working to take over the whole thing. We see that happening in Medicare Advantage. We opened the door. Some people said it's not true, but some people say, they're more efficient, so you got to let them in and get this competition. Well, let's look what's happening. The worst healthcare system, healthcare plans are the Medicare Advantage plans. They have networks that are limited. They deny care. They make it delays happen. They exclude the best cancer institutions, and yet they're the ones that are growing. The competition doesn't work. I mean, they really are what makes it wrong. And, there are some things that shouldn't be a profit-making business. We say you can't have child labor. You can't turn that into a profit-making business because that's immoral and unethical, and we don't allow it. You can't make a business out of offering a hitman because that's illegal. You can't do it. It's immoral and we as a nation don't allow it. And we have to come to that conclusion on healthcare as well, that you can't make a business out of controlling healthcare in a way that cheapens healthcare for our people and results in massive suffering and death. It's just not right, and we won't allow it. People can make their living in some way that is more honest, and their souls will feel better.
Kay, I absolutely agree with everything you've said about the for-profit health insurance companies. Having said that, Australia, Canada, New Zealand, and even the United Kingdom have figured out ways to have some representation or some amount of private for-profit health insurance in the. I'm not saying it's a good thing, but I'm saying it's a reality that these countries have all seemed to be able to figure out a way to balance in that equation without allowing them to dominate the system the way they do in this country. Garrett, your thoughts about that? Where do you see this playing out?
Well, as like you, I second everything that Kay has said, and the problem is the insurance companies, and it's awful. At least that's part of the problem, and there's a lot of problem with the provision of medications and pharmaceuticals in this country that I would also address, and that it will be taken care of with the Medicare for All Act. There is an allowance, I believe, in this. I'm not for certain about this iteration of the act, but the previous iterations would allow for cosmetic surgery insurance and something that's not necessarily necessary for life-saving or good health. And I forget what it was. I was.
Let me just make a comment. I agree with everything you've said, but we have to face the reality that we are on the righteous path, but the popularity of these plans, particularly the Medicare Advantage plan, is now up to 50%. And the for-profits have convinced people that this is a good plan. And the patients that I still see, I'm going in the home and seeing patients for a company, and that would be a long story, but most of them have the Advantage plan, and I asked them, are you happy with your insurance? And over 90% of them say that they are. They don't realize what could happen if they got very sick and had to go to rehab. But the vast majority of Medicare patients are happy with their Advantage plans, and I think that we're going to have to educate the public about the problems with this, and Congress is going to have to investigate it. Now, one of the things that I'm interested in, who is responsible for all this? Is it the for-profit companies just taking advantage of what CMS has offered? Because it looks like to me that CMS has pushed the Advantage plans, and most people don't know what they are, and they've given incentive for the for-profits to take advantage of it and to really make a lot of money. There's Humana, as you know, is putting all their eggs into the Advantage plans. And there are other companies who are really rapidly advancing and going to, looks like, take care, are going to dominate primary care and Medicare patients, particularly those with Advantage plans. CVS, United Healthcare, is making phenomenal steps toward this, where they will control almost all those patients. The CVS will have, they've recently bought a lot of physicians, and United Healthcare has too. They will have these physicians in their drugstores. They will dominate their pharmacy. They own an insurance company, and they also will own a pharmacy benefit planner. So how are we to address this? And the question I have for you, who's responsible for starting this and keeping it going? And is CVS or is the federal government partly responsible for this? And I want to we'll talk about this, and then I want to go to the ACOs that you tell people what they are and how they affect what this new bill is trying to correct.
Kay, before I let you answer that, let me make a similar comment to Gene's. I have the same concern about CMS. These direct contracting entities started there. They've evolved into ACO REACH, which also is being maintained by the Biden administration. So you got to scratch your head sometime and think what's going on in Medicare. You know, what's going on in CMS, where these basically these programs that are basically efforts to privatize it are being supported. So Kay, the floor is yours, and Garrett, we'd like to hear from you as soon as Kay is finished.
Well, these are complex and profound questions, but I think that getting at the point that these private companies couldn't be taking over this public Medicare if it weren't for the legislation and the administrative body, which is the Center for Medicare and Medicaid Services, allowing them to do so. And I think we have to look at the problem that, you know, sometimes it's called capture. It's when the body, the governmental body that is supposed to regulate something becomes virtually controlled by the industry that profits from that particular program. And if we look at who's who in this situation, we find that Liz Fowler, who came from Anthem, WellPoint, as the vice president, wrote the bill, the Affordable Care Act, that included the section that allowed the Center for Medicare and Medicaid Innovation to come up with all of these programs that are expanding into all of these places where they're controlled by venture capital and private equity. And you can go back and forth. Adam Baylor was Trump's head of the Center for Medicare and Medicaid Innovation. Now he's doing venture capital in something called Rubicon. Andy Slavitt was a Democrat involved in overseeing the Medicare program, and he's also involved in many of these programs. Zeke Emanuel was in the Obama administration, and he is one of the funders of these venture capital things. So we see that there's an interchange between the people that are profiting from healthcare and the governmental positions. Humana's chief medical person, a guy named William Schrank, was the chief of evaluations in the Innovation Center in Medicare. So they go back and forth. And instead of serving the public and the patients, they're more likely to be serving the industries that are trying to profit from it. And we have to tackle that. And we have to expose it, and we have to get our government to take it on. We're making a little bit of progress. There was an October article in the New York Times that says the cancer was insatiable, speaking of Medicare Advantage plans and how they cheat and how they're cheating the Medicare Trust Fund. So we're getting a little bit of it out there. A couple of days ago, Blumenthal in the House held a hearing about Medicare Advantage plans using artificial intelligence to automatically deny claims. So that was brought up about the extent to which people are being denied care. And I would say that we're beginning to make a dent in it. Just today, I saw an article in The Nation written by Adi Barkan that raises the whole issue as to whether Medicare is totally being destroyed by the Medicare Advantage plan. So, you know, we're beginning to tackle it. I would say that I think that Medicare Advantage is not so much popular, but because it costs less upfront on a monthly basis, that combined with the fact that most of our seniors are on limited fixed incomes, means that it's been positioned to have the advantage of being cheap basis. So we have to tackle the whole thing, and you know, to save traditional Medicare, but I think to do that, we have to go to a Medicare for all system. And yes, it is CMS, it is inside the government, and they go back and forth between being the chiefs of the government bodies and the chiefs of the private equity venture capital firms.
Can you explain to us what an ACO is and what they're trying to do and how they're expanding that?
I can try to do that, Gene. You know, we laugh at it because the definition, even by those who created it, is so amorphous that nobody understands it. It means accountable care organization. And basically, I like Kip Sullivan's definition. It's the new HMO. It's new managed care. You know, we had that taking over our healthcare system in the 90s, where, what are they called? Health management organizations, where it's managed care, and they were going to crush out the extra expenses by managing the care. And we had a rebellion in the country because we got, you know, new moms being sent home without, you know, being properly evaluated, and we're having drive-through mastectomies. So people rebelled against HMOs and managed care. Well, ACOs are the new managed care, and they function under this CMMI that was in the Affordable Care Act. And they are the gateway to letting profits into the system in a massive way. And, you know, one of those plans is that ACO REACH, which is claims to be solving our problems of racial and economic disparities. In reality, it is converting us into a wholly privatized Medicare system if we don't stop it.
Scary business. Garrett, your thoughts?
Well, I think we're having the benefit of one of the country's best minds on this program. We just heard it from Kay. I did think of what I was trying to remember a minute ago when I was talking. Um, um, Wendell Potter, who was a health insurance executive with Cigna and couldn't stand it any longer, and it got away. He wanted to. He was a whistleblower on the problems that and the problems of the health insurance companies, having been an executive there. And he wrote about, recently he wrote about um, pharmacy benefit managers. And I think Gene mentioned CVS. CVS Aetna has a pharmacy benefit manager called CVS Caremark. And that's the pharmacy benefit manager, which is a pharmacy benefit manager is a middleman at the center of the U.S. pharmaceutical system that are hired to negotiate rebates and fees with the drug manufacturer, and they also control the formularies, and they reimburse the pharmacies for the patient's prescriptions. But CVS's or Cigna's, CVS and Aetna, it is. CVS Caremark is the pharmacy benefit manager for CVS and Aetna. They contribute more to the company's revenues and profits than either Aetna, which is the health insurance company, or the company's 10,000 retail stores. At Cigna, it's Express Scripts, which generates more in revenue and profits than the health plans. So this is just another point against the privatization and the commercialization. And I'm constantly remembering Dwight Eisenhower's warning to beware the military-industrial complex. And in the case of healthcare, modern healthcare, it's the medical industrial complex.
Well, again,
Yes.
these are all examples of a healthcare industry focused on profit, making profit from all healthcare activities, as opposed to a healthcare system that is focused on providing healthcare to its citizens. And unfortunately, as a matter of full disclosure, I am a registered Republican. I've been a Republican all my life. I'm not going to go into the details of the last time I voted for a Republican, because I don't want somebody throwing rocks through my windows at home. But as long as we have this large majority, and a lot of this majority is the result of redistricting and gerrymandering in legislatures, it's going to be a tough sell to get past all this. And the only other option, as Kay has mentioned earlier, we need a huge public education program to try to get some information into the brains of people who are going into the ballot box and voting for people who promote policies that are against their health and economic self-interest. Jane?
These the for-profits are just rapidly taking over. We're at least at 50%, and they're going strong to consume even Medicare, and they already administer most of Medicaid. So I don't, and we talked about just a few minutes ago that we have to get the patients to understand that this is not good, but right now, most of the patients are happy with what they've got. And the reason is it costs them less. They get the little trinkets. The companies buy blood pressure cuffs, and they are able to buy over-the-counter drugs. They get cash every 2 or 3 months, and the patients really like this.
Yeah, Gene, that's fine, because as long as they don't go somewhere else or get really sick, because that's
Right.
where we are the only first world country that has anywhere from 200,000 to 800,000 individuals in this country that file bankruptcy because of medical debt. And 60% of bankruptcy filings in this country is medical. I agree with you, but it's a really, these people are not stupid. They've figured out how to provide really, really good small benefits to people, and cover up the risk that they take by not having good health care coverage. When they get really sick, hits the fan, and they end up with medical debt. France, country of 70 million, had one medical bankruptcy in 2017, and we have somewhere between 200 and 800,000 a year. Now, we're a bigger country, but we're not that much bigger.
Well, also, a lot of those people who go in medical debt have commercial insurance.
Yes, but they have lousy health care coverage.
Right. They have huge deductibles, and they have when they get into a major problem, the insurance doesn't cover it all, and so they go into to a debt situation. And unfortunately, the hospitals and physicians too, particularly those owned by hospitals and equity companies, don't forgive those debts.
Yeah. So we've got 5 minutes left. Kay and Garrett, we've all talked about how to educate the public about the issues that we're talking about, that we all agree about. So I'd like to hear both of your thoughts about, what we need to do. We're here, we come here once or twice a month, and we talk on the radio, and we have an assortment of, sometimes a lot, sometimes not so many people listening to us. But within our own medical communities, they often don't understand some of these issues. I'm surprised at how many people think that Medicare for all, it means that they're going to take over healthcare. Then, Mitch McConnell goes around yelling socialism, and when it's really just a government health insurance program. So how do we get the word out to the public that needs to know about it, so when they go to the ballot box, they'll be thinking about these things instead of thinking about guns and
I'll just try to speak quickly to that, and I appreciate you bringing us back to that point. And that I've been thinking about it in anticipation of this program again, because we need it. We need this improved Medicare for all, and it would do so much good and relieve so much suffering. I think we continue to magnify and to speak to the problems that this dysfunctional health situation, and I appreciate Mike, your pointing out it's not a system, non-system, and I think we have to do that. We have to help people to understand that it doesn't have to be that way. This is a new way, and this is a good plan. The Physicians for National Health Plan has endorsed this Medicare for All Act, and I'm going to do what I can to try to push it forward because it's got so much good in it that we really should do everything we can to get it forward. We also are welcome Bernie's bill. It's not quite up to the standard that PNHP requires, but it's certainly a good start. And Bernie himself is a wonderful champion.
There's one other thing I think we need to talk about. You just touched on it, and that's infant mortality rate. And what's going on in rural America is going to dramatically increase that. We now have multiple rural hospitals closing, and we have a lot of hospitals stopping doing OB, and that's going to create a really serious problem. People in labor having to travel 50 miles. The other thing that's just recently happened in the state of Idaho. They've lost about 50% of their neonatologists and high-risk OB doctors, and that's certainly going to increase infant and maternal mortality.
We're down to 1 minute. Kay, you want to make a couple of quick remarks before we pull the plug?
Well, I share your concern, Mike and Jean, for the work you do to bring the truth to the public. And we in Kentuckians for Single Payer Healthcare have programs about Medicare privatization, about single payer healthcare. They're free. You can get in touch with us at kyhealth.org, and we'd be glad to come to your organization and speak about it and lend you what we know and share that, because we got to educate everybody in the country to make the move we have to make to win.
That's a great way to end. Kay and Garrett, thank you both very much. This has really been an interesting program, a lot of good information. I'm sorry, Mark is going to take us out.
Okay, Kay, Garrett, always good seeing you guys. Just one thing, it's not all gloom and doom. Kay and Harriet had an op-ed published in a state nonprofit news organization's letter. It's called the Kentucky Lantern, and Kay and Harriet really nailed it regarding the Medicare disadvantage program. So Kay, thanks for all your work on that front. Just want to remind listeners that we'll be celebrating the passage of the Medicare Act here at the end of July. So please mark your calendar. Join us for that celebration. That's going to be Sunday, July the 30th at 2 p.m. It's a free event at the main office of the Louisville Public Library down here at 3rd and York. We'll have a documentary that we'll be showing. It's called The Power to Heal, Medicare and the Civil Rights Revolution. And it's based on David Barton Smith's book, The Power to Heal. And it is an amazing story, and just really encourage folks to mark their calendar for Sunday, July the 30th, 2 p.m. So, Jean, would you do a better job of getting the foxes out of the hen house, because there aren't going to be any hens left in the Medicare program.
You're absolutely right.
So anyway, guys, thanks again for another terrific program. And thanks to our listeners and the support that you've shown the station during our fund drive back in April. Thanks for listening.